We'll have a few more people joining.
Good deal. Well, it is a little bit after 9, and we always promised that this echo would, we'd make sure that we were on time. So welcome. I'm so happy to see everyone here. It's December already, which feels hard to believe, but it is. And we're very used to Zoom now. Everybody's got their face right in the middle of the camera. That's awesome, so that we can see you and we can interact. So this is a collaboration between Missouri Telehealth Network and the Heartland Telehealth Resource Center. We're so glad you're here. And my name's Janine Gracie, and I have the pleasure of moderating these sessions for you. So sorry if anybody else had difficulties today getting in. It was, I thought I sat down at, the right time at 8:30, and I was having a lot of trouble this morning, so I apologize for that. So what we like to do is to make sure that everybody knows that where everybody's from. So if you would take your cursor and right click on your picture, and then there's a little box that comes up and you can hit rename. And if you would kindly put your state next to your name, that allows us to answer your questions more appropriately so that we know what state you're coming from. Because, all 3 states are a little bit different when it comes to some of the regulations and telehealth policies. So if you would do that, that would be great. So we're going to start by introducing the hub team. So I'm going to start with Dr. Edison.
Hi, everybody. Karen Edison, Senior Medical Director of the Missouri Telehealth Network and our Show Me ECHO program.
Great. Thank you, Karen. And I'm not supposed to use titles. Remember, I did the first faux pas, okay? So we'll go with Evelyn Nelson next.
Good morning. Great to see everyone. Thanks for your perseverance with the technology. I'm a psychologist at KU Med Center and also PI for the Telehealth Resource Center. And I just wanted to welcome Dr. Klemp.
Wonderful. Rachel.
Good morning, everybody. I'm Rachel Mutro, the Senior Program Director for the Missouri Telehealth Network and the Show Me ECHO at the University of Missouri.
Thanks, Rachel. Robert.
Oh, Heather's fine. Hi, I'm Robert Stiles. I'm with University of Kansas School of Medicine, Department of Pediatrics, but also work and help out with the Telehealth Resource Center. Glad to see everybody.
Great. Thank you so much. All right, Tim.
Good morning. Tim Davis, Telehealth Manager at Oklahoma State University Center for Health Sciences, and I work with HTRC in Oklahoma.
Wonderful. Thank you. And Heather.
Good morning, everyone. My name is Heather Hagan. I'm a telehealth analyst at OSU CHS.
Wonderful. Thank you so much. All right, since we have a smaller group, we're going to go ahead and have everyone introduce themselves very quickly. So, Cece, we're going to start with you and have you tell them what your role is.
Hi, I'm Cece Vangel. I'm a telehealth coordinator with Missouri Telehealth Network and also with Show Me ECHO. And my job is to help everyone get on the call and make sure the call can happen.
Thank you so much. And boy, were you needed this morning. Okay, thank you. Angel.
Hi, I'm Angel Goldberg. I'm an RN and I'm a school nurse in Maplewood, Missouri.
Great. Glad you joined us. Thank you so much. Franz.
Good morning, everybody. I'm Franz. I'm the Student Education Coordinator for Mid-Missouri Area Health Education Center.
Glad you're here. Thank you so much. Let's see here. We're going to Jeff.
Good morning, Jeff Samborski. I'm the Community Engagement Specialist for Platte County, Missouri in the Kansas City area. University of Missouri Extension.
Great. Thank you, Jeff. I'm so glad you were able to join us. Trika.
Good morning, everyone. I'm Trika Young, and I'm one of the outreach workers here at Missouri Telehealth Network. And my job is to recruit participants for this ECHO. Good morning.
Wonderful, thank you. And we have Katie.
Good morning, I'm Katie Knight, and I work with the University of Kansas Cancer Center and Dr. Klemp. I'm the program manager for Can Survive and another project that's coming up soon too. It's nice to be here.
Thank you, Katie. Glad you could join. Wanting? Oh, yeah, we got you on mute. Still can't hear you. If you go down to the left. Oh, there you are. Yes, there you go.
Good morning. My name is Wanting. I work at the Better Health as an RN on surgical medical rehab unit. Thank you.
Thank you. Thanks for joining us. It's wonderful. All right. And we have Shelley.
Hi, I'm Shelley Cooper at Diversity Telehealth, and I do quite a bit of work with asthma ready communities and the parent advisory group there. Glad to be here.
All right. And Ahmad has told us that he has a practice in pediatrics in Mexico, Missouri for over 40 years, and his microphone does not work. So sorry, I can only introduce myself through the chat. Well, we're so glad you're here. Thank you so much for doing that. Next is Rachel.
Hi, I am a nutrition and health specialist for Phelps, Dent, and Crawford County, which is located near Rolla and Missouri S&T.
Great. Thank you, Rachel. Glad you're here. And Maggie.
Hi, everybody. I'm Maggie Gross. I am the project coordinator at University of Missouri St. Louis for Tritons United Against Gender-Based Violence. And I also have a private practice doing clinical therapy work as well.
Wonderful. Now, did I get everybody? I think so. All right. Thank you so much for those introductions. That helps us get to know you, and we're just so happy that you're here today. So, some announcements. So we do use first names during these echoes so that we can just get to know each other and have more of an interconnected environment. Please be conscious of any confidential or protected health information so that, you know, if you do want to speak or ask a question, that type of thing, just make sure that we're not divulging any of that important protected information. If you have questions, go ahead and type those into the chat. You can also ask those questions after the didactic is over, so you don't have to type in the chat, or you don't have to ask your question out loud if you choose not to. Please keep your microphones on mute until you're ready to speak if you do ask a question. And all of this information, the presentation will be available on Box. You should all have access to that by now, but if you are new, you just, and you're having trouble getting onto Box, please let Cece know and she will help you out. Sometimes there's a little trickery to it. The value of ECHO is in the cases. So if you would ever like to present a case study to this ECHO about telemedicine, it doesn't always have to be about the topic that we're talking about. So if you have some kind of telemedicine case study that you need some assistance with, please don't hesitate to join in and make sure that you deliver that to us so that we can review that. All right, so here we are with the time for the didactic. All right, so Jennifer Klemp, I'd like to introduce Jennifer Klemp. Dr. Klemp is a member of the University of Kansas Medical Center's faculty. She focuses on risk stratification to identify and manage the effects of cancer that negatively impact the quality of life and impact cancer risk. So her research interests are cancer risk and genetic education and testing, any issues related to the quality of life and survivorship in cancer survivors, as well as improving the access to point of service through telementoring. So Jennifer, we're going to let you provide that didactic now. Glad
Great.
you're here.
Thank you all so much, and so nice to meet you and be part of your ECHO. As you heard, I am at KU at the University of Kansas Cancer Center, and this about 20 minutes that we'll spend on our didactic is going to kind of talk about this community of practice that we are building across Kansas that was focused initially on cancer genetics and has really evolved into a sustaining survivorship ECHO series. I think the important part about kind of what we've learned, and I am not a ECHO expert. I am a cancer person who's worked in oncology for about 25 years, is that this is a really great way that, we've been doing a lot of point of service training and collaboration. We do a lot of telehealth, but this really gave us a nice framework in the telementoring space to be able to formalize this community and not only have regulars like you guys do, but also new folks as well. So we are so glad to join you. Here are my disclosures if you are interested in those. So we started our ECHO journey with a grant from the Pfizer grants for learning and change through the Association of Community Cancer Centers. And this was a really nice opportunity to have a structured question and really do an ECHO series to help us not only sort of build our team, and as you can see, Dr. Evelyn Nelson is one of our teammates, and very important, not only because I've worked with her for a very long time, but she is, in my opinion, a ECHO expert, and that was a needed partner as we started learning and sort of expanding our resources. So I focus on this team because it really was essential, just like we heard from your hub, of putting the right people together to make sure we had those different scopes of practice, what lanes were people in, and how do we support each other in our goals. And so the goal for this ECHO series was really to use tools for telementoring, with ECHO being the platform, to increase point of service genetic testing for patients with breast cancer. And this is not only a priority because of the number of patients being diagnosed every year with breast cancer, but there's a very high percentage of them that actually will have hereditary breast cancer. So probably as high as about 15%, which definitely impacts not only how we screen them, how we treat them, but also definitely impacts their family through what's called cascade testing. So this has become a priority, not just for the cancer community, but also the CDC has taken this up and has really started pushing this initiative out through state health departments and other kind of boots on the ground resources, and trying to really reinforce the importance of people knowing their risk, having access to education and counseling and testing. So we really looked at this grant opportunity as a way to do that. We, just like you, have a catchment area that is a huge footprint. We go into the western edge of Missouri. We go down to Oklahoma, but not into Oklahoma. But we all kind of tend to support each other, especially in that lower southwest corner or that lower south corner of our state of Kansas. And so we know we have a huge deficit, not only because we don't have any genetic counselors outside of Kansas City, but this is a lot of space with not necessarily the most dense population. So how should we serve them best? So we really tackled the initiative through inviting partners through the Masonic Cancer Alliance. And the Masonic Cancer Alliance is the outreach arm of the University of Kansas Cancer Center, which is an NCI designated cancer center. And we are the only university medical center in the state. So through our outreach arm, we have partners, and as you can see through the pins, in particular, we recruited sites, but also there were participants from lots of other areas, but those sites were recruited, if you will, formally through the Masonic Cancer Alliance. We developed 5 one-hour project ECHO sessions or clinics. We evaluated and really tried to focus on how could we embed some metrics and maybe maybe some practice improvement. Knowledge change is great, but how could we really start measuring, does the ECHO series really have an impact on the question that we were trying to ask, which is, are we increasing the number of patients who actually get genetic testing? And so we use the organizational readiness survey for implementation and change. We built a REDCap database for registration, onboarding. It is definitely a very slick tool that I think we spent a lot of time building, and has been utilized now by others. And the quality improvement piece that we put into the series, we did make it optional because we didn't want that to be a barrier to sites participating in the ECHO series. So here are the topics that we covered. Obviously, you guys are familiar. We just heard Janine do a nice summary of how ECHO works. And so these were the topics we took sort of in a stepwise process. And then we built a really nice functional toolkit, which I'll show you some of these resources. So this was part of the quality improvement if sites chose to participate. It had a little bit more of workflow analysis and really trying to look at some pre and post testing rates, but required a kind of an additional level of commitment. And the sites that opted to participate, of the 8 sites, 3 of them opted to participate in the quality improvement, and they had accreditation standards, like things like what we have in oncology, something called the Commission on Cancer, which is a hospital-based accreditation. And this was a way that they could actually use this quality improvement project to meet one of their quality standards for that accreditation. So this is our website, and you're free to go there. And what we decided to do was we built a tab on the side, and it's called telehealth, or telementoring, sorry. And through the telementoring tab, we have 2 different series. We have our genetic series and our survivorship series. And this is where we not only link people with each other, but we also have all of our recordings minus the, oops, I'm sorry about that, minus the patient case studies, because we do want to protect confidentiality, but you have access to the recordings, the slide decks, the template forms, anything that you need to participate in the ECHO is all housed on the website. This was sort of an example, and I'm going to click through these really quick, of some of the tools that we put in for workflow analysis, really showing them not only, okay, what do we want to look for? Where is it happening? What's the process? Who's doing it? How is it documented? We really wanted the, and this is sort of an example, where's the sample collected? Who collects it? So this allowed the practices to really see a lot of gaps when they didn't have those boxes completely filled in, and some opportunity, or they saw that they had good redundancy, because a lot of the processes we do in clinic do unfortunately need to have some redundancy. So this was sort of the workflow analysis that they completed. And so after the 5 series and after the quality improvement project, we decided to really start diving into how can we use all the data we collected and start looking at kind of some metrics. So overall, we had 76 participants. Now, not on every session. Every session averaged about, we averaged still about 24 unique participants per session. But this was a nice distribution of providers, which really was a target for this ECHO because it was targeting cancer care teams, and it was targeting a quality metric for cancer patients. They felt that our communication with them was adequate, and that's where we had kind of those lanes where our team members really had very specific roles. And we tried, just like you guys do, I got communication from CC, and that was the main person. We have a CC named Tracy, and that all communication goes through that single person. Participants responded that they were much more comfortable interacting through the chat box. I'll talk about some of our barriers to engagement, which I don't think is unique to our ECHO. And about half the folks participated in putting their face up, or the video part. So, you know, that always tends to be a little bit of a challenge of how do you get people to show their face if they're driving? We get it, but it is still nice to see everyone, and that leads to increased engagement. And then we also tracked our Google Analytics, our website analytics. And I think this was a really helpful metric. So by putting all those resources on a website, are people going to use it? Who's going to use it? And so what this allowed us to do is not only see the unique page views, which is pretty decent, but having over 2 minutes on an average time on a page is actually quite high. So that means that people actually went to the website, used the resources, people accessed the recordings and the slides. And so I think this is another way of really keeping that engagement going, and another interesting way to try to kind of take a different view on outcomes and metrics as part of an ECHO. The other piece we looked at, obviously, was this organizational readiness for implementing change. The questions can be wordsmithed to your target. So as you can see, people who work here are confident that the organization can get people invested in implementing point of service genetic testing in breast cancer. So overall, the readiness was pretty high, which is good. And they felt that they could keep that momentum up. So the enthusiasm was there, and the participants had the enthusiasm. But is this really going to happen? So the interesting part is, for some, yes, absolutely. We know that we had good participation in the sessions. We got good feedback on the content in the sessions, and about 50% did report an increase in genetic testing after completing the ECHO series. So is that an increase of 20%, 50%? We don't have that level of detail, of granularity on how much increase they saw, but they did increase based on awareness, based on hopefully implementing some of those best practices that were discussed in the ECHOs and through the cases. But they did identify some barriers. If there wasn't that clinic champion, the change wasn't going to happen. They needed to have the organizational commitment, and they needed a motivator. And maybe the motivator was the accreditation standard or something like that. So this really kind of hones into, I think, 3 very translatable outcomes of barriers, not just for implementing cancer genetic testing, but really any type of clinic change that we hope to achieve. So it did reinforce that. So what are our lessons learned? It was very helpful to work with a strategic partner that already had a network where we could build on that trusted relationship. We participated at that time, obviously in person, in a kickoff meeting, and we went to the Masonic Cancer Alliance annual meeting. Dr. Nelson joined me along with Dr. Nye, one of our other co-investigators, and we did an in-person session to almost 100 people that were attending the meeting, and that was a really great way to get people enthusiastic about the opportunity. It was a way to kind of meet those stakeholders and recruit them. We spent probably way more time than I had anticipated or thought about on building the content and the cases, but we wanted it to be really value add. And I wasn't sure how to dilute that down to something more scalable, because we just wanted, people to get the value and to feel like their time was not only respected, but they were going to get something as a return on that investment. We did ask for observation, since this was our cancer first ECHO. We asked for observation and feedback from the what I call the mothership in New Mexico, and we got great feedback from the team there. We tried to use and leverage technology, and especially in trying to get people to engage. So not only did we early add in polls as part of our questions, specifically about some of the content that we were covering, or we used a poll question early on to sort of right size where the group was in relation to the topic that we were covering that day. We definitely used the chat box more, because people told us, okay, now we kind of know everybody, so can we just check in sort of in the chat box? And even though that's not a preferred method, once you start building that familiarity, it allowed us to accelerate, because people wanted to jump right into the content of the cases. So when you're working with busy clinicians, they're not used to more of the social network that we have built around ECHO. So we tried to balance that, and we still did a check-in, but people could check in via the chat box as well. And then really trying to use some of the analytics from the websites. It was hard to get people to turn on their cameras. And, obviously the practice facilitation takes more time and commitment. So when we're really trying to look at metrics of change and change over time, I think it's hard to do that because it requires a different level of organizational commitment, of data collection, and of practice change. So how do we sort of have surrogate markers for change? And I do think that that's an opportunity we have with ECHOs in general, is not only looking at some of the traditional ECHO metrics, but how do we sort of start building some of these surrogates that can be very useful in looking at the impact of the participation and the time and the return on investment of ECHO. So we know that this is of interest to our providers. We know that the telementoring really was a great opportunity to keep that community going, but we still, I feel, have some limitations in regards to our measurement and quality improvement, and this gives us some opportunity. We also heard from the community though that they wanted more. So our future directions are we'll continue this, but we also built an ongoing survivorship series. So this survivorship series continues. This is the spring version that we meet the second Wednesday of every month from 4:30 to 5:30. We keep that standard, as do you. And we did an ECHO COVID mini series in April covering specific topics that were of concern to our catchment area. And this was really, I think, a value add of having an existing community that we could leverage very quickly into a response to a pandemic. So that was nice to have. This is our website for the Cancer Survivorship ECHO series. So similar to what we have for the genetic series, you can access all the agendas, the session recordings, and the toolkit, which on each slide where we have resources, we have a little red toolbox. And so folks don't have to go and try to hunt down those resources. They're all under the toolbox, under the resource kit. So everything is aggregated for them. This is our team. As you see, our core team, this is our hub. This is our cancer hub, I should say. We have a lot of folks working on ECHO at the University of Kansas Medical Center, but this is our cancer team. And I want to thank you for your time, open it up to questions, and thank you guys for the opportunity to share sort of what we've been working on in regards to cancer in your neighbor in Kansas.
Wonderful. Thank you so much for that informative presentation. It's really cutting edge and unique. So thank you for that. That's wonderful. All right. How about questions? Anyone have questions? I know you do. Don't be shy. I'm looking in the chat to see.
Jen, what did you find, and you probably covered it, but I'm thinking about it now. What was the biggest barrier to testing for the most part did you find out with these providers?
So I think that just like anything else, whether you're screening, maybe you're working in tobacco, and I want to translate this because I know a lot of you don't work in cancer, but I think we have some lessons learned. And so I think the biggest piece is, understanding what your process even is, right? And understanding that when resources are available or guidelines change, or we have tools for education and assessment and intervention. And in this case, an intervention would be testing, is it being systematically used? So the first thing was every time there was kind of new staff, you don't always do the level of onboarding that probably would be value add when you're embarking on something like genetic education and testing. So I think that ongoing staff training was a barrier. I think that another challenge that the sites had was worrying about kind of when to do that, right? So they needed to really think about it in the workflow and make it part of that kind of workup or differential versus thinking, oh, well, we'll get to that, or we can address that at another visit. And then the third, I think in regards to that is there's still some perceived barriers in regards to, well, how will this information really impact our decision-making today? And so it was making sure that the providers understood how this was value add from the time of treatment planning and why this was valuable, not only for surgical management, but now for chemotherapy choices, and then for ongoing survivorship. So really kind of giving them those updates and having a way to provide like what I like to call is like a bolus, like a little nugget, like here's here's your updates, because national guidelines change pretty rapidly, especially in cancer. And it's really hard to keep up with those changing guidelines. So having this sort of forum gave them an opportunity to get that nugget all at once versus having to go and dig for those updates and resources.
Jennifer, this is Karen. We're thinking about doing a precision health and cancer care echo in Missouri. And we're thinking about doing it, you know, I'm a dermatologist. Before I retired, I was chair of dermatology here at the university, and we have the same issue with melanoma. You know, the same issues exist with all kinds of cancers with this genetic revolution. And so all kinds of healthcare providers need to know about this so that they can get those markers, they can get that genetic analysis of that tumor at the beginning so that their patients can have access to the best treatments. And my question for you is, we're trying to conceptualize how to do it. And it just sounds like this was a big project and a lot of work just around breast cancer. You know,
right.
More, so like, you know, breast cancer for a month, and, you know, kidney cancer for a month, and lung cancer for a month, and melanoma for a month, and ovarian, you know, we were thinking about doing it like that, but do you think that's unrealistic?
So a couple things. We just got another grant through the same mechanism that we will initiate at the first of the year, which is for renal cell, so for kidney cancer. And that will allow us to talk about topics like genetics, immunotherapy, and so forth with the examples, the case examples of renal cell carcinoma. So one predictor for this, I hate to say, is you need ongoing funding to cover the requirements of what this takes to deliver. The second is I work with a group out of Jackson Lab in Boston and the Maine Cancer Initiative. And that group has been doing a very interesting kind of molecular precision medicine tumor board for the past few years. And in the state of Maine, they are fully sequencing every new cancer that happens in the state. And you're probably aware of this. You probably read some of their information. Through one of the cooperative groups, so in cancer, we have groups of people who are at lots of institutions, community sites, and we all do shared clinical trials. But through the cooperative group, that one of the largest one, SWOG, I met this very wonderful physician, Jens Ruder, and he's at Jackson Lab and runs the Maine Cancer Initiative. So he had heard about our genetic echo, and they did the molecular tumor board via just traditional sort of telehealth plus boots on the ground. And so we've been trying to merge those two concepts into more of that precision medicine concept, and people could bring cases and so forth to it. And so in doing that, we were not conceptualizing it as a month per tumor type. It was more based on the biomarker target. And the reason is that, and I just did a precision medicine summit keynote for the cancer support community yesterday. So I'm fresh on all this nomenclature and terminology, which is really a disaster in precision medicine right now. But the nomenclature is so complicated for patients and for providers. What's happening is that we have a drug like Keytruda, for instance, that isn't just for a specific tumor type anymore. These are called agnostic drugs. So if we chose a particular tumor that to start with, then we'd be talking about a lot of different markers that I think could be more confusing than if you talked about the marker and the different cancers that are surrounding the marker. And so there's two ways to come to it, two sides of the coin. And so we were coming to it from the biomarker side of the coin, whereas you would come to it from the tumor side of the coin. And I don't know if there's a right answer.
I just don't know if we need to teach everybody everything about every checkpoint inhibitor. You know what I mean? Like,
trust me, I get that. I totally get it.
As primary care providers, I have a patient with this cancer. Let's make sure we do the right things on the front end to give them every opportunity. That's kind of where my head is.
So where I have an interest, and maybe we need to chat about this, is that we want to train especially a lot of our safety net clinics and clinics that use what we call our early detection works, you call Show Me Healthy Women, those clinics to do basic risk assessment at the time of a well woman visit, right? So how are we getting genetic risk assessment done at that point? Because we do have services for them and we can get patients testing. So I think that there are some synergies that we probably have that are much more on that basic level, because you really have two levels. You have the molecular tumor board and really hardcore precision medicine. And then you have, what does everybody actually need to know and what could they apply in their daily job? And I think that's where we probably need to spend more time. And then these more precise molecular tumor boards are needed, because a lot of our rural and community providers don't have any place to present these cases. So I think we have some real dichotomy to address, but I'm with you on this bucket over here.
Can you speak more to how you did structure the cases? I was really struck when your team presented. It was really talking through the practicalities of how do you work for the testing company, and some of those real practical things that I think was new to the audience.
So one of the things that was, as I heard Janine asking for cases earlier too, getting people to provide cases is really hard. So through these relationships, and luckily I've known these practices for a long time, I would personally reach out and get cases, and I wouldn't care if they would just send me some notes and I would write up the case for them. That is pretty much how I did it, which was okay. But then having them present the case. So I think one thing was really getting those real cases from the people helps so much, but it's so hard. So the personal reach out is essential. The second was, I do depend on a lot of our genetic testing companies to be the boots on the ground in rural Kansas in particular. So it is important to have relationships with industry partners that are transparent, but also that allow us to extend our reach, because we don't have the ability to go and so many of the clinics that are doing testing, they don't have even adequate nursing support. So they're using tumor registrars and medical assistants and you name it to fill some of the roles in a workflow. So having somebody who can go in and help them with a lean process or the workflow, boots on the ground, was really helpful. And so that's where we did use the extension of our genetic testing company partners to help us with some of that. So it's sort of like using every resource and tool you have. And that was new for a lot of them. And I think was pretty helpful though in helping them with their workflow, because we can only be so many places. And I love going out to all the sites, but it's not the best use of anyone's time. So we have to make sure we use those in-person visits as sparingly but as productively as we can.
Excellent discussion. Thank you. Any other questions? Well, we've learned a lot in a short amount of time, Jennifer. I don't know how you got through that didactic that quick, but you did. It's a lot of good information. So we thank you for that. And we will definitely, I think, make sure that we have your information in box so that if somebody needs to contact you, they'll have that information. That's
and I think we did talk last week with a few people on Karen's team. And so that was really nice to meet some of your team and had a good discussion about an RO1. There's Myrna. Hi, nice to see you. So it was really great to hear what you guys are up to. And I think there's some good synergy, and I owe Myrna some stuff. So I will send you that as well. Okay.
Thank you so much. And thank you for this presentation. It was very, very awesome.
Great, thank you. All right, well, we are going to continue our series on into 2021. We're ready to kick 2020 to the curb. I don't know about you, but I am. But I want to let you know that we will continue this series at second Tuesday of the month at 9 a.m. Put that on your calendar. In January, we're going to talk about telemental health update during COVID-19. Jonathan Neufeld, who is a fellow Telehealth Resource Center a colleague and a psychologist, is going to talk more about that update. And I think it'll be an excellent presentation. In February, we're going to talk about school-based telehealth in Oklahoma. So stay tuned for that. I think you'll learn a lot from that. In March, we're going to talk about a telephysical therapy study, which is a fairly new mode of using telemedicine that they're actually getting reimbursed for at this point. But this study is happening at the University of Kansas Medical Center, and I think you're going to learn a lot from that study. We also have telehealth efforts for tribal health on the books for the spring, as well as the patient perspective. So stay tuned. You all were incredible in providing us some information on what you would like to see in these telemedicine echoes. So I thank you for that. And so we listened, and we definitely tried to make sure that we could get speakers for those topics. So with that, if there are no more questions, then we are going to go ahead and sign off. Wish you happy holidays and a very happy new year, and we'll see you in 2021. Thanks. Bye.